First topic will be building global trauma capacity, and our speaker is Dr. Shailvi Gupta of University of Maryland, USA. Dr. Shailvi Gupta is a trauma and critical care surgeon. She's an assistant professor of surgery at University of Maryland Medical Center, Baltimore, Maryland. She has master's in public health faculty, University of Maryland School of Medicine, an affiliate faculty of the Howard University Department of Surgery. She's also a resident site director at the University of Maryland Capital Region Health, a member of Maryland Committee on Trauma, and she is awarded as the Future Trauma Leader by American College of Surgeons Committee on Trauma. So everyone, let's all welcome Dr. Shailvi Gupta.
Hi, my name is Shailvi Gupta. I am a trauma surgeon and critical care physician through University of Maryland School of Medicine and the Shaw Trauma Center program in trauma based in Baltimore. It's really a privilege and an honor to be involved in this Asian Collaborative for Trauma. Today I'll spend the next few minutes discussing building global trauma care capacity. It's a big topic to discuss in such a short time. My email address is here, so please feel free to reach out with anything if I could ever be of help. So quickly to start, my goal today is to discuss about global trauma care, kind of why trauma is such a big deal globally, and I think this group and audience kind of understands that, but I'll go over a few numbers. Then I'll talk about trauma systems, focusing a lot on how the US developed their trauma systems, and then kind of broadly discuss trauma systems globally, and then delve into trauma care capacity and what we need to do as a trauma community to help improve trauma care globally. So to start, trauma really is a global pandemic. It's estimated that about 1 person in the world dies every 5 seconds as a result of traumatic injury. This amounts to about 5.8 million trauma deaths worldwide annually, 32% more than malaria, tuberculosis, and HIV combined. This number is a little bit dated, within the past 10 years, but this gives you an idea of the breadth of how big a deal traumatic injury is globally. Injury deaths are predicted to rise by about 40% and become the 4th overall leading cause of death in a few years by 2030. Low and middle income countries, not surprisingly, suffer the greatest burden of injury, with greater than 90% of injury deaths coming from low and middle income countries. So the volume is the greatest in low and middle income countries, but it also is the impact on society is greater in low and middle income countries. Injury-related mortality in LMICs is twice that all that amazing trauma care is limited if we can't get our patient to a center that has these innovations and these treatments quickly. And this is where trauma systems become crucial with regards to taking care of the trauma patient. So the birth of trauma systems, what does this mean? A trauma system provides an organized approach to provide rapid initial treatment and optimal care along a continuum from pre-hospital care, so when the injury happens, through rehabilitation to getting the patient to be an active member of society again. The organization of the process of trauma care delivery is really crucial to optimize outcomes. So we have to do all of this on this continuum very, very well. So in the US, the history of trauma care really parallels our history with regards to the military. A lot of our concepts, again, with regards to resuscitation and triage, come from the experience that our colleagues have experienced on the battlefield. And so these are a few pictures. One on the left is from the American Civil War, and this is what developed a rapid evacuation system. And this happened in the 1860s. So ambulance corps and placing surgeons near battlefields to help triage who could return to battle, who needs to be transferred to hospitals. This was the beginning of triaging patients, creating aid stations, and rapidly transporting patients. Throughout the different wars, different things started to happen. So in World War I, where there was mass casualties, this propagated a triage system through tiered echelons of increasingly capable treatment. So military colleagues would definitely know this a lot more in depth, but there are different stations, different hospitals have different capabilities of where people would get rapidly transported depending on what type of injury and how expedient they needed care to be delivered. Then the adoption of motorized transportation like helicopters happened in the Korean War, which again, improvements happen with all the subsequent conflicts. By one estimation, the injury to surgery time improved quite dramatically. From World War I, it was about 18 hours with a mortality of 8.5%, to the most recent data that we have from the Vietnam War, where the injury to surgery time was about 65 minutes, with mortality being 1.7%. Who knows? A lot of things have changed within that time with regards to trauma care delivery, but at least the injury to surgery time really started to decrease quite a bit with regards to improved trauma system development. So this idea of a need for a structured trauma system started to overflow into the civilian trauma world, and the civilian spotlight happened not until about the 1960s. So while, in the war, people were learning how to do this in the 1860s, we didn't follow suit for about 100 years later. So what happened was there was an act that came out, the Accidental Death and Disability Act, which termed trauma the neglected disease of modern society. They highlighted that injury was the leading cause of death in young people, so the first half of one's lifespan. It highlighted the deficient emergency medical care capacity and urged the establishment of trauma registries, hospital trauma committees, and increased funding for trauma research. So it's the first time that really there was a federal agenda that tried to dictate and demand that trauma be made a priority with certain establishments to help improve trauma care. So while this was happening throughout the country, there are a few things worth mentioning. Cook County Hospital in Chicago in 1966 is really it is the nation's first trauma center, and it consolidated all trauma patients into one dedicated trauma team unit. So Cook County Hospital is known to be the first trauma center in the United States. In addition to that, around the same time, our Adams-Cali Shock Trauma Center, what I call home, it became the first organized trauma system in the United States. And so what happened is the governor of Maryland established MIMS, which was the Maryland Institute for the Emergency Medical Service System, and he partnered this system with the Maryland State Police to provide helicopter transport, which really greatly increased the sophistication of trauma care in Maryland. And this collaboration between the police and between the MIMS emergency medical services really helped reduce trauma-related mortality by transporting critically ill patients from the field or other regional hospitals to a dedicated shock trauma unit where patients could get expedient care. And this also highlighted this idea of the golden hour, understanding that within that first hour, getting prompt medical treatment after a bad injury really has the highest likelihood to prevent death. So again, while these improvements were happening throughout the U.S., these were two institutions that are worth mentioning for helping build trauma care. So I want to take a few minutes and tell you this story, or what I call a tale of two cities, between Baltimore and Milan, Italy. So these are two of my mentors. On the left is Dr. Oswaldo Chiara. He is a trauma surgeon and the head of trauma at Niguarda Hospital in Milan, which is the first level 1 trauma center in Italy. And on the right-hand side is Dr. Thomas Scalia, who's the chief of trauma currently at R. Adams Cowley Shock Trauma Center. So these two have a very close relationship, and how it started is Oswaldo Chiara, he is a young surgeon in Italy, and he really was a rebel of sorts in that he had this idea that he wanted the ability to really care for the whole spectrum of a critically injured patient. And while I call him a rebel, what I mean by that is in other parts of the world, other than the US and Canada, trauma care isn't really prioritized. And people don't necessarily see that trauma surgery should be a field of its own and understand, the critical care aspect and really how to manage a patient wholly in that aspect. Sometimes in different parts of the world, trauma patients are handed to the orthopedic surgeon or the anesthesiologist. And so the trauma surgeon is really a unique entity that is starting to change culture throughout the world, but really is ingrained in the United States. So Oswaldo, because he had trained in the US, he understood this and he really wanted to push this in Italy. And so he was rotating in Baltimore. And one day he sat with Dr. Scalia and he was explaining to him that he had autopsy data. He had data from Milan that showed that over 2 years, 43% of deaths were either definitely or potentially preventable. So if you take a step back and think about that, that's almost half of the deaths that occur in a metropolitan city in Italy could have been prevented with appropriate trauma care. So what did Dr. Chiara and Dr. Scalia do? They published it. They published this data because data is power. You have to have numbers to try to be an advocate. And so they published this saying that we're really not doing a good job of taking care of injured patients in Milano. And so subsequently from there, Dr. Chiara was actually fired from his hospital because the government of Milan thought that he was exposing something that was quite bad, that the people that Milan wasn't taking care of its population. And so he was really reprimanded for publishing this. Fortunately, Oswaldo was giving a talk and a politician from Milan heard Dr. Chiara speak and really was motivated to facilitate change and care for the injured patient. And so if you can imagine, Professor Chiara was trying to advocate for trauma care in a place that didn't believe trauma surgery needed a place and didn't believe in his endeavors. That's why I put this picture here that Oswaldo keeps in his office that one of his residents gave him because he really was going against the world. So this politician gave Oswaldo the opportunity to build a trauma center. He said, I will give you this space and this much money. You build a trauma center and show me what you can do. So Oswaldo did. He did. He built the the Ospedale Hospital Niguarda Trauma Center, which again is a level 1 trauma center in Milan. With the help of Dr. Scalia, he based it off of Shock Trauma Center. They have an amazing few resuscitation trauma bays, which they call the shock rooms. They have the CT scanner on the same floor. Immediately, patients can go to the OR. They can go to a hybrid unit. And now the preventable death rate in Milano is 3% and probably a little bit less. This really is trauma prevention at its finest. You get a place that really doesn't have an organized trauma system, isn't able to have a trauma center. You put one there and you decrease the preventable death rate by a significant amount. So this is, to me, a very cool story of how trauma systems can really help change the mortality of the population. In the world, we have many different kinds of trauma systems. Trauma care delivery really has a lot of variation, both regionally, we can say that in the US, and internationally. And there's no right or wrong answer to this. And to focus on a single system would actually be inappropriate because there are things that might work in certain places of the world and things that might not. There's so many things that we have to take into consideration based on socioeconomics, geographical characteristics, medical organization, the epidemiology of trauma in that region. We really have to consider all of this. And so according to the region of the world, the development and organization of trauma systems really has to be adapted to local needs. In general, and I don't have a slide on this, but just to kind of mention it, there are two ideas of trauma systems, an inclusive system and an exclusive system. So in an exclusive system, you have certain hospitals in an area that are designated in specialized trauma centers. So this could be good in an urban setting if you have this regionalized trauma center that's readily available to you, but it might not work so well if you're far away from that type of system. An inclusive system is a bit different in the sense of all healthcare facilities within a region are involved in the care of the injured patient in some way, shape, or form. There could be different tiers. In the United States, we have level 1, level 2, level 3 centers, and the emergency medical system triages patients based on their level of injury to the appropriate care. If they need to go to the highest level, level 1 trauma center, or to a lower level should be sufficient. And so that's an inclusive system where all hospitals should be capable of taking care of the injured patient. And so those are the differences. One might not be better than the other, but studies have shown that a more inclusive system tends to get better outcomes of care. There's also a significant amount of variation with regards to pre-hospital care. It can be organized in very different ways in different parts of the world. For example, in the US, we have this idea of scoop and run, where we have our EMS colleagues or emergency medical technicians who are trained in BLS, basic life support, and sometimes in advanced life support, and they can give they can put in an airway, they can give certain medications, and the idea is to get them to a dedicated trauma center as soon as possible. And this is called the scoop and run strategy. In other places, for example, in Europe, the pre-hospital system is based on highly trained paramedics or doctors. Even, for example, some places in Europe, the anesthesiologists or surgeons are on the helicopter or the ambulance. They can do a resuscitative thoracotomy, they can do chest tubes easily, they can do advanced airways, and so that's another system that exists. Neither is better or worse. It depends on what capabilities you have, where you need your physicians. Do you need them in the EMS system, or is it better served that they are at the hospital? So it just depends. Again, you have to adapt to your local environment. The idea remains the same. Get the right patient to the right place at the right time. That is what a trauma system ideally tries to do. So shifting a little bit to the development of trauma systems in low and middle income countries, a little bit different. In 2004, the World Health Organization really wanted to improve trauma care globally, and their goal was to reduce the disparities in injury outcomes between low and middle income countries and high income countries by establishing achievable and affordable standards for injury care worldwide. We know, and I'll show you where we get this data, that it's 6 times higher a chance of death in a country with no organized trauma system. Where does this data come from? So this comes from Dr. Charles Mock, who's based in Seattle at Harborview Medical Center. He really is a father in some ways of global trauma care. And in the 90s, he did this study where he looked at a high-income country, the US, middle-income Mexico, and a low-income country, Ghana, and tried to evaluate their trauma systems and their mortality. And what he showed was that people with life-threatening but potentially treatable injuries are up to 6 times more likely to die in a country with no organized trauma system. And so this kind of goes to show you that trauma systems really do help mortality. So then what we know, again, and this is something I love saying to my students and my residents, but data is power. Like in medicine, knowledge is power. When we try to advocate for change in research and systems, et cetera, we need data. Like Oswaldo had, like Dr. Mock had, and we need data to prove that this is a problem. Where do we get data with regards to trauma? We get it from trauma registries. And what are trauma registries? So broadly defined, trauma registries is a dedicated data repository of trauma patients. They're databases that document acute care delivered to patients hospitalized with injury, gives you demographic data, they can be used to improve the efficiency and efficacy of trauma care. We know that trauma systems reduce mortality. And trauma registry, the data, so that we know what kinds of patients we are seeing, what types of injuries we are seeing, what we need to be prepared for, a trauma registry is really a key driver of improvements in trauma care. And again, trauma registries are used to describe injury epidemiology, track quality indicators, benchmark trauma care, and really advocate for injury prevention. It's considered an essential component of mature trauma systems, but the existence in low and middle income countries is sporadic at best. And if you work at any trauma center, even the highest trauma centers in the US, getting an up-to-date trauma registry is really hard to do. This study was done showing the global distribution of trauma registries, and what this shows is that the majority of trauma registries where we have good data is from the Western world. And then you look at different low and middle income countries, sub-Saharan Africa, there are only 8 trauma registries. How are we going to provide good trauma care if we don't have the data to dictate what we do? I helped develop with some of my Canadian colleagues a trauma registry in Mozambique, and it was really hard. When we were able to do it, we got a year of data. What we realized was less than 5% of injured patients arrived by ambulance. What this tells us is that there's a need for a pre-hospital system. People are coming in with their families, and other countries have been really clever in how they bring patients to the hospitals. Some places in South America use the police to bring patients and have taught them basic life support things. And so you need to adapt this. What we learned in Mozambique is there really wasn't a good pre-hospital system. Only 13% of patients received a complete clinical trauma score. We use the Kampala trauma score, which is a little bit abbreviated, but even with vital signs, neurologic status, and age, only 13% of patients got a complete evaluation. So doing a trauma registry kind of highlights as well what care we're giving to the patients and what data are we missing. This registry, what it forced us to do was to describe and provide a structured clinical approach to patients, ensuring that severely injured patients are identified first. I remember taking call with a few of the surgeons in Mozambique, and there was no organized system because it just hadn't been done yet. And so this kind of helped force that move. The challenges, of course, with anything, higher rates of missing data, difficulty in establishing a streamlined flow of trauma care. If someone wasn't there at all times kind of highlighting how to get this data, it was really hard to implement the streamlined flow of trauma care. The goal was to roll out this trauma registry nationally, but because of political instabilities, that was delayed for a bit. And because there was lack of uniform resource allocation and low personnel in many areas, it was really hard to keep going, meaning we couldn't get 100% of data all the time if someone wasn't there. So in short, implementing trauma registries is really, really, really hard, like really hard. And so if it's hard anywhere, we just have to understand we need data to advocate for trauma systems, and getting the data is hard, and we need to figure out how we can do this better. So then taking a step back, and I'll just go over this a bit quickly. So we talked about trauma systems, talked about trauma registries. Now what about trauma capacity? Do we have the ability to care for the injured patients once they come to the hospitals? So a few of my colleagues, again from Canada, and Dr. Kushner, who I know some of y'all know, we tried to look at a review of trauma capacity in low and middle income countries. So what we did is we looked at 12 criteria: basic resuscitation, pulse ox, fluids, endotracheal tube, etc., to see what hospitals had available to them. So we looked at 531 hospitals in 17 countries. Not one had access to all 12 criteria. Endotracheal tube and cricothyrotomy or tracheostomy were only present in about, let's be generous, about half of the hospitals, and bag mask valves were about 61%. 87% say they were able to provide initial resuscitation, but only 50% about had a blood bank. So even these basic 12 criteria were not available in many countries. We then wanted to take a step back and published what's called the INTACT Index, which is 40 different criteria, which we deemed important to be able to take care of a trauma patient. So these range from having electricity to an intensive care unit, a CAT scanner, to being able to do an amputation, and open, a tracheostomy, an airway, general anesthesia, laparotomy, to different types of equipment. But at least this gives us a general idea of the trauma capacity at a hospital. We then took another step further and thought, okay, there's trauma capacities. What about even water availability at hospitals in low and middle income countries? What we noticed was less than 2/3 of hospitals providing surgical care in 19 low and middle income countries had a reliable source of water. And this ranged from under 20% in Liberia to over 90% in Bangladesh and Ghana. So if we're wanting to provide trauma care globally, there are a lot of steps that we have to do in order to make this happen. And it's a really hard task. So providing trauma care capacity really is a complex web. It ranges from having the appropriate surgical services, population factors, geographic factors. Do we have the ability to reach our populations? Capacity, do we have surgeons? Do we have the infrastructure? Do we have the resources? Education, is ATLS available? Do people know what the standards of care are to do? Quality and safety. It really, key drivers to increase trauma capacity really form a complex web. And ensuring access to trauma care as a right requires a reliable, accessible, and sustainable health system in order to provide constant trauma care. And this is a hard ask. And so this is why I wanted to touch on a lot of different things, because it's not just one thing that we do to fix improving trauma care capacity globally. So we, as a collaborative, have to help each other move forward together is key to success for improving trauma care globally. We have to create sustainable and productive global partnerships, share our knowledge, share our education in a two-way format to really improve trauma care globally, which will save lives. And we as a global trauma community have an obligation for these relationships. And I think, again, this collaborative so that we can continue to try to improve trauma care globally. So that's my talk, and I really do appreciate this opportunity. And by all means, please reach out if there's any questions or anything I can help answer. Thank you.
Thank you so much, Dr. Shailvi, for that very comprehensive talk. Thank you for guiding and touring us to this building global trauma capacity. Now, for all your questions, kindly type into the Q&A box that will be later on this answered during the open forum. Now, let me have the honor again to introduce to you the reactor for this topic, building global trauma capacity. She's our colleague here in the Philippines, Dr. Esther Saguil. She's an associate professor of Department of Surgery at the University of the Philippines College of Medicine, the training officer, Division of Pediatric Surgery, Philippine General Hospital, and also the chairman of the Department of Outpatient Services in the same institution. She is the president of the Association of Women Surgeons in the Philippines, chair of the Committee on Surgical Infections, Philippine College of Surgeons, and the founding and current president of the Philippine Surgical Infection Society. She is also our vice president of the Philippine Society for the Surgery of Trauma. So everyone, let us all welcome Dr. Esther Saguil to give us reaction on the Building Global Trauma Capacity talk.
Thank you, Malu. And good morning, everyone. I would like to congratulate and thank Dr. Gupta for her very enlightening talk. And it's so great to hear your perspectives halfway from around the globe. We're here in the Philippines, and I know we're on different time zones now. So if it's early here, I know you're up very late today. When you said that trauma was considered a pandemic before the COVID situation came in, I certainly agree with you. And in fact, much of our efforts in trauma management got derailed when the COVID pandemic came in, because suddenly everybody's focus was in infection prevention control. Thankfully, the trauma incidents also got very low, really dipped during the early part of the pandemic. Unfortunately, now it seems to have undergone a surge too. So we all know that our trauma capacities vary around the globe, and I'm very happy that you underscored the variation, the difficulty in getting very good trauma care when you're in a very low or middle income country, in contrast to somebody who is in a high income country. And even here in a low middle income country like the Philippines, there are also varying capacities, and that depends on the individual area. Like, for example, we have hospitals here that parallel already big hospitals in the US. But by and far, the majority of hospitals will be somewhere in what we would call the secondary, or the very minimally 50% prepared for a trauma, for being a proper trauma center. Also, one thing that we need to also highlight is that we do know how to manage trauma, but you also mentioned that prevention of trauma should also be highlighted. And that's particularly more true now when we have several problems that are known to have been documented, and we have the data that they do increase trauma, the incidence of trauma. And what are these? Drunken driving, drug addiction, and its resultant problems. Your current problem, particularly in the Western world, gun controls, mental health. Everywhere we're having trauma as a result of problems with mental health, and the absence of regulations that will prevent various trauma from happening. And it is not without effort that they have been trying to build up trauma registries everywhere. Efforts have been undertaken since almost 30 years ago. And you're right, it's very, very hard. I love that slide. Really, really hard to make a trauma registry. The reliability of data is just not up to par. We have to consider the investment of individual surgeons, nurses, pre-hospital caregivers, and that is a big problem. And I think it is up to we have to have advocates. We have to have champions, and that's why we also have a PSSD. I'm very glad that Dr. Gupta is also another champion in trauma care. We have to have advocates, and thankfully here in the Philippines, we just started the Trauma Commission, and National Trauma Registry is up in the offing. So we hope, really hope, that eventually we will have at least an acceptable national and global trauma center or capacity system that we can be proud of, and we can be sure that if just in case we were the ones to be the victims of trauma, we will be well taken care of. You mentioned about scoop and run, and in pediatric surgery, which is my specialty, most of the scoop and run we have is the baby falls, somebody scoops the baby up, takes the whatever vehicle is available, a bicycle, a tricycle, a car, a taxi, and brings that baby to the hospital. No more care as to what to do in the pre-hospital setting. We hope that with the enlightenment of our departments or ministries of health, we will eventually have a much better uh, trauma care system, which will include the pre-hospital time that the trauma appeared, so took place, so that we will be better improve the outcomes of our trauma care. So here's to, I know this is just the ASEAN collaboration in trauma, but eventually there will be a global collaboration on trauma. So thank you very much. Thank you again. Back to you, Malu.
Thank you so much, Dr. Esther Saguil. Great talk, brief but excellent talk. I totally agree that I usually emphasize also on the trauma registry and pre-hospital care. Thank you again to our speaker.